Good morning.
Right. Yeah, so we got a nice quorum. See here if we have enough. I guess we got just about everybody. Okay. It's a somewhat shortened conference today. I apologize. Okay. This is a tracing from a 20-year-old who has hypertrophic cardiomyopathy and had, actually it was a generator change. And this tracing was obtained on postoperative night 1. So my question for you is, what is the rhythm, and what should we do about this? So we go to, I think Perna Bonsall is on the line. So let's see what Perna has to say about this.
Good morning, Dr. Paz.
Good morning, Perna.
So here, when I'm looking at leads 1, 2, and 5 in the beginning, I see somewhat broad, wide QRS complex, but not as wide as at the end of the strip. And then if I follow through, it seems like there could be a P wave, or this could be the T wave of the preceding QRS in the beginning of the strip, but then we lose that and there is wide complex QRS morphology. And was the patient hemodynamically stable with this?
Would you expect the patient would be hemodynamically stable with us?
No, so it's like ventricular refib right here, broad complex tachycardia.
Mm-hmm. Okay, so so what would you do for this rhythm?
We would cardiovert.
Would you cardiovert or would you defibrillate?
Defibrillate. So it will be.
And how many joules would you give this patient?
2 joule per kg.
Right, 2 joules per kilo.
Mm-hmm.
And yes, go ahead. I'm sorry.
And then we would check the pacemaker. That why did it not the pacemaker? Sorry, we'll check the ICD. That why did it not trigger appropriately at the time when it should have?
Right. So, is this a long enough period of time for the device to have fired? Can you tell from this tracing?
I cannot tell exactly. Is the strip underneath just a continuation of the one above?
Yes.
It takes about.
It's a continuation.
It takes about 8 to 10 seconds for the.
How do ICDs? How do you program an ICD? You said it takes 8 to 10 seconds. What is that based on?
Like it analyzes the rhythm and then it charges. So it takes about 8 to 10 seconds to deliver a shock for the ICD.
What is it that's taking 8 to 10 seconds?
First, the ICD analyzes and then it charges.
So the ICD is a supercomputer, so should be able to analyze it much faster than you or I can. So what parameters can we program in an ICD for this type of circumstance?
The upper rate limit of the.
Well, it's not called the upper rate limit. What is that called? It's the detection zone, right? So you want to tell the device, at what rate should I consider this rhythm to be fast enough that I would want to defibrillate or cardiovert the patient. Okay. So typically, you have to tell the pacemaker or the defibrillator what rate that is. And you also have to tell the defibrillator how long do you want to wait and what are the criteria. So usually, what we do is we tell the defibrillator that we want a certain number of beats to meet a certain criteria in a certain period of time. So, for example, it might be like in a Medtronic device, it would usually be that it would tell you like 12 of 18 beats or 12 of 16 beats. So it's constantly checking 16 beats. And if 12 of them have a R to R interval that is equal to the rate you have determined or chosen, the device will start to charge. But you can also make it longer. You could make it wait, for 32 out of 36 beats or 48 out of 52 beats. So it's constantly looking at a window of a certain number of beats in order to determine. And the reason that it's not asking for 100 out of 100 or 12 out of 12 is because, as you see in ventricular fibrillation, the QRS complex and the ventricular electrogram are changing from beat to beat. And so in recognition of the fact that the electrogram may change in size, the defibrillator is programmed to essentially look at an average over a period of time. And how long it takes the defibrillator to charge and to detect and shock someone is based largely on the program. So the first variable that we can control, as I said earlier, is what rate do we want it to detect. And so usually in young people, we set that rate very high because we don't want sinus tachycardia to potentially be misinterpreted by the device as an arrhythmia. So we'll often set it well above 200, like 210 or 220 even. But this rate clearly exceeds that. The next thing that we do is we try to give the patient a chance to spontaneously terminate themselves. And so we will often set a wide range, at least the equivalent of, 2 to 4 seconds of sensing in this arrhythmia. So that gives the patient an opportunity to potentially terminate on their own. But the other benefit of that is also that the device may not shock as much, right? Patient will come out on their own, and so we'll use less battery. So that's another benefit of a longer detection zone. And then the other determinant is how much energy we want to deliver. So the higher the energy that you ask it to deliver, the longer it will take the device to charge. Modern defibrillators take only about 3 to 4 seconds to charge to full amount, maybe 5 seconds at most. So you're correct that usually we would want it to be at least about 8 to 10 seconds of arrhythmia. And of course, the other benefit of a longer charge time or a longer detection zone is that the patient will be unconscious. And so we would rather that when a patient gets shocked that they not feel it, because it's quite painful to be shocked. So the other big benefit of a longer detection zone is that if a patient is in VF, they will be unconscious, in reference to your first question as to whether this patient would be conscious with this rhythm. Now, there's a fine line. The longer you're in VF, the harder it becomes to defibrillate somebody. That's been well established. So it's sort of a fine line between just enough to be unconscious, but not too long that it's harder to defibrillate the patient. So if you were looking at this tracing, Perna, what would you, so I think we both agree that this is a long enough period of VF that the patient ought to have been defibrillated by their device, but clearly it does not appear as if the patient was. And I will tell you that the patient actually, a code was called because thankfully the patient was on the adult side. This was way back at Columbia, 20 years ago. And the patient was actually on the adult side on telemetry. And so a code was called and the code team came in and they externally defibrillated this patient. It's a sinus rhythm. So what would you have expected would be, I think we both agree that the rate is fast enough that almost no matter what the device was programmed at, it should have detected this and defibrillated the patient. So what would you expect is the problem without even having interrogated the device?
If the lead has moved, it's post-op night 1.
What do you think is wrong with the lead? What I agree, it could have moved, but why would movement of the lead potentially be a problem? And I agree with you, it could be a problem. Although I'll remind you that this was a generator change. This was not a new system. But if it were a new system, that would certainly be a very significant concern.
So if the lead it has moved and it's not in contact with the wall, then it would not sense properly. So that's why it might not really pick the ventricular fibrillation, like the beats that they're beating. Actually, it's fast.
That's correct. It certainly, that would be the biggest concern if the lead moved, is that it wouldn't sense properly. So this seems to be some kind of a sensing problem. What if I told you that during generator change, we actually induced tachycardia and the device properly sensed and defibrillated the patient? Because that's actually what we used to do. We used to, on every single generator change and in every single new defibrillator, we used to always check a defibrillation, well, we wouldn't call it a threshold, but a margin test to make sure that there was at least a tangible safety margin between what the device can deliver and what was actually needed to defibrillate the patient, and the max of the device, of course, and also that the device could sense. And during the induction, the patient actually what happened was VT was induced, and the patient's device detected the VT and sensed it and shocked the patient out. And this was with an old lead. So old leads don't generally move, although it's always a good answer, because if it were a new lead, that would be the most important consideration. But why do you think it is that a lead that we had that had been in there for a number of years, that had just worked great, 6 or 8 hours ago during the generator change, all of a sudden seems not to be sensing at all?
If while putting the generator back in, if the lead kinked.
Right, you could injure the lead during a generator change. And in fact, we always tell patients that there is a risk that we could injure the lead. And that's one of our biggest concerns when we're doing, there's really two concerns when you do the generator change: injuring the leads and infection. Those are always our big two concerns when we're doing a generator change. So yes, that's a good possibility that the lead was injured, but in actuality, as I've explained, after the device was changed out and after it was already in the pocket, we did a defibrillation threshold test and it was successful. In other words, the lead, after it had been changed into the new device, was sensing correctly and was able to defibrillate the patient. And yet here, 8 to 12 hours later, it seems like the patient is not sensing properly. This is pretty scary, right? I mean, we do not keep people overnight after generator changes anymore. Thank God this young lady was in the hospital when this occurred, or else she probably would have died. What actually happened is that, this is a not insignificant issue, which is that VF is not the same as VT. When we put a device in, we try to induce VF through the device. There are multiple EP study techniques that are available in all defibrillators to allow us to induce VF. But sometimes we're unable to induce VF, and instead we induce VT. And all VFs are not the same. Even on this one tracing on the bottom half, you see that the QRS is changing constantly. And in fact, what we saw when we interrogated this device was that it was sensing VF, but then it would undersense a lot of beats to the point where it didn't meet the criteria for, say 16 out of 20 beats at a rate above a certain amount. And so then it would reset itself. So it would sense, say, this much, but then it would not sense anything here, or it would think the rate was much slower than it was, because the electrogram in this arrhythmia was changing and at times was very small. So even though the R wave was like 7 millivolts, and even though it sensed quite well in ventricular tachycardia during the generator change device procedure, in the actual clinical arrhythmia that the patient had, it did not sense properly. And in fact, when you looked at the download from the device, what we saw was that after interrogating it, that it did see that there was tachycardia, but then it kept thinking that the tachycardia had terminated when it had not. So now you have a patient who has a lead, and I might add that the R wave again was 8 millivolts, and its threshold was low, and it seemed to be sensing in sinus rhythm perfectly. So what would you do at this point? Or what could you do?
Reprogram it to have a lower threshold.
Well, you mean to make it more sensitive, right? Not a
Yeah.
threshold. So threshold is a term we use to denote output for pacing, right? So yes, you could make it more sensitive, but in actuality, it was already pretty sensitive. It was programmed at one of the more sensitive settings. So you really, and it wasn't, couldn't reliably say that would work. So to be honest, at the time, I wasn't sure what to do. So I went to the literature and I read a little bit. And what I learned was that this has been described. And interestingly, this patient had what's referred to as an integrated bipolar lead. And what that means is that all ICD leads have a bipolar lead, meaning that they're sensing between two electrodes at the tip of the lead. And the reason it needs to be bipolar is because bipolar sensing is more accurate than unipolar sensing. Remember that in unipolar sensing, we're sensing between the tip of the lead and the actual device itself. And so that means that if a patient has a lot of skeletal muscle stimulation, like they're doing chest exercises or they're lifting their arms, it's possible that the device may oversense that as ventricular activity and potentially inappropriately shock people. So all defibrillator leads are bipolar. But the manufacturer of this device, which happened to be a Boston Scientific device, uses a technology called an integrated bipole, where they basically have an electrode at the very end, and the other electrode is the actual coil towards the end of the lead. And so the distance between the distal electrode and the coil is a little longer or wider than in a typical pacemaker lead. It's about 2 or 3 times as far. And so there have been reports with this type of lead of it not being as accurate as what is sometimes referred to as a true bipolar lead, where the bipole at the electrodes at the end are spaced similar to a pacemaker lead. And so Medtronic, for example, uses a true bipolar ICD lead, whereas Boston Scientific to this day still uses an integrated lead. And you might ask, why would they do that? The answer is because what we're looking at here is quite unusual. Most of the time, integrated bipolar leads work fine, and those leads made by Boston Scientific have a very long track record of excellent longevity and strength. So in this case, the options would be either to extract the lead that's in there that failed at sensing and put in a new dedicated true bipolar lead. So you could put in a Medtronic lead, which has a true bipolar, or you could put in a so-called dedicated rate sensing lead. In other words, you could take a pacemaker lead just a plain regular pacing lead that you would use for a pacemaker that has a true bipole at the end, put that into the ventricle next to this lead and use that as the sensing lead, and use the defibrillator lead that doesn't sense as well, but still seems to shock well as the shocking lead. And it's interesting, in the present era, I think most people would extract the lead and put in a new lead. But at that time, first of all, extractions were still fairly novel. And second, devices all had different sized pins, meaning that if you had a Medtronic lead, the part that plugged into the defibrillator was a different shape and size than a Boston Scientific one. And you needed all of these little, what they called adapters, which would make a much more bulky end of the lead. And it just created a lot of bulk and complexity to the operation. Now, at the present time, shortly after this, in the early 2000s, the United States government mandated that all pacemaker and defibrillator leads be so-called IS-1 leads, meaning that they all fit into the same header of any device, meaning that you can mix and match and put a Boston Scientific lead into a Medtronic device and vice versa, or St. Jude, or any company that you like, Biotronic. But at this time in 2001, you still had this problem of lead mismatch. So the idea of putting in a Medtronic lead, like a Medtronic ICD lead, and attaching into this now brand new ICD, that was a pain in the neck, because you would then have to create this extra bulk in the pocket because of all of these adapters, which of course probably were a mechanism for weakening the lead as well. And so basically what we did in this case was we put a dedicated rate sensing lead in this patient. So she had two leads. We did that the very next day, and then the device sensed properly, at least during one test in the OR. And she actually had multiple shocks over the next 10 years that were appropriately sensed and defibrillated. And ultimately, this patient with hypertrophic cardiomyopathy could only be controlled from VT on amio. Without amiodarone, she would have multiple episodes requiring multiple shocks. And eventually, because of concerns that the chronic amiodarone would cause pulmonary fibrosis, she underwent a heart transplant about 10 years after this episode. But this is a scary episode because it demonstrates how defibrillators are not infallible because of the lead. And also shows that, you know, today we would never think twice about sending a patient home after a generator change. But had this patient gone home, she probably would have died. So it's a scary case I'll never forget. All right. What is the rhythm in this adolescent? I think we'll ask Dr. Grace Kong what she thinks about this.
Hi, Dr. Paz.
Hi, Grace.
So I'm going to start actually by looking at the very bottom strip, or the very bottom rhythm. And I do see P waves before some of the QRSs, but not on the very first one. And the PR is definitely changing in duration. It looks like it is lengthening. I'm not sure if at the end of this there is a dropped P.
I will tell you there's not.
Okay. In that case, with the QRS, it's not regular, so it does seem to be all conducting with the P. I don't think this is complete heart block. And the P waves are not regular in intervals with each other. Is this called wandering pacemaker, Dr. Paz?
No, you're thinking about the so-called wandering atrial pacemaker. Is that what you're?
Yeah, I know, but that's different. The P wave morphology.
Right. So in a wandering atrial pacemaker, which is a normal finding that's sometimes used in describing Holter findings, typically late at night, patients may, when they're in sinus bradycardia, have non-sinus atrial rhythm. That's almost at exactly the same rate as the sinus rate, maybe slightly faster. And so you'll see, you know, if you want to think of it as an ectopic atrial rhythm that's very slow, So that's an old-fashioned term. Sometimes I'll use it in describing it in a Holter. I usually refer to it only when you see it late at night when somebody is sleeping. That's a normal finding. But this is, I think we would agree, the P wave is basically the same in all. When you see a P wave, it all looks about the same. So I don't think this is a wandering atrial pacemaker. Also,
Yes.
this is not in the middle of the night. I blocked out the time for privacy purposes, but this was done, I don't know, in the late morning. So patient was awake, was in clinic, obviously, so was not asleep.
Okay. Actually, now that I'm looking at it, I think it's initially junctional. The patient is very bradycardic in the beginning. So the P waves, when they do come in more frequently, I think it's conducting appropriately. The PR seems a little bit long. So there seems to be first degree at the about like last half of the EKG. But in the beginning, I think the P waves, the atrial rhythm is so slow that the junctional rhythm is coming in and that it's coming in faster than the P wave conducting. And that's why the PR is so short. So it's
That's exactly right. Yeah, that's very good, Grace. Excellent. And at the right-hand side, right, we see fairly consistent PR interval, right?
Mm-hmm.
And so how would you describe this now? So now you've sort of think you've got it all. So how would you describe this if you were going to, someone's in the emergency room, you're seeing this patient, you're calling me at night, I don't have a fax machine or a cell phone. How would you describe this rhythm to me?
Thick sinus node syndrome, I would call it. Intermittently bradycardic with intermittent junctional rhythm.
Okay, and what about the conduction when there is conduction?
First degree heart block when there is conduction.
Right. So I would say that this is someone with sinus node dysfunction with junctional, with some junctional rhythm and then first degree heart block. So I agree with you. These beats here are probably not being conducted. And actually the R to R on all of these is pretty consistent. So this is just basically junctional rhythm with what we would sometimes refer to as isosynchronous atrial depolarization that's occurring roughly the same time as the QRS, making it appear as if they're conducting, but the fact that the R to R interval is pretty fixed suggests that they're not conducting. And yet these beats here are actually coming in a little faster, right? The RR interval on these is a little shorter than on these. And that's because for whatever reason, the sinus node finally woke up a little bit and we have sinus rhythm with a long PR interval, first degree heart block. So this patient is asymptomatic. So how would you evaluate this patient? What would you do? What are your concerns about this patient? Would you evaluate this? This patient was referred because of chest pain, which has resolved.
So I guess one would be to try to figure out why this is happening, and two would be to see if this patient needs treatment for this. In terms of why this is happening, I would get an echocardiogram.
And what are you looking for in the echocardiogram? I know that's our go-to pitch for everything. Why are we doing an echo here?
Look for signs of anything that would explain myocarditis, pericarditis.
Okay.
And I would also look at
and what is the finding that makes you think that the patient could have myocarditis? I'm not disagreeing with you, but what is the electrophysiological finding that makes you concerned about that possibility?
The first degree heart block.
Yep, I agree. First degree heart block could be a residua of myocarditis for sure. Okay. So you do the echo. Anything else you're interested in the echo?
Function, I would want to know since the patient's so bradycardic.
Right. So the echo shows normal function. And I might add there's no holes in the heart in case you were considering a pacemaker.
Great. And we would send some labs.
Yeah, okay. What kind of labs? Are you going to send a histiocytosis X panel? What are you
At least we'll start with the inflammatory markers and line panel COVID.
COVID, that's interesting. Yeah, could be COVID. I will tell you that this patient actually has had this for a number of years, but if you were first meeting this patient, yes, a COVID would probably be a good idea, right? Because there have been some reports now of people who have block from COVID, although I believe in the vast majority, as in other forms of myocarditis, they resolve, but it's not 100%, I'm sure. Okay, so the inflammatory markers are negative. Anything else you would do? She says, by the way, she feels fine. She had that chest pain, but it has resolved.
I would get a Holter and evaluate what her average heart rate is.
Okay. Any other blood work before we go to the Holter?
Blood work. Oh, thyroid studies and catecholamines less. No, thyroid studies. Just thyroid.
Right, you'd want to do thyroid studies because hypothyroidism can cause bradycardia, heart block, things like that. We did that actually, and those were negative, thankfully. Any other infectious workup you would be interested in? Maybe you already mentioned this, but Lyme disease, right? I think maybe you already said that.
Yes.
And we sent the full panel Western blot, and that turned out to be negative. Okay, so now you're doing a Holter. Now, why are you doing a Holter? I'm not disagreeing with it. In fact, I think it's a great idea. But what are you looking for on the Holter?
I want to see how long the patient is in a bradycardic rhythm.
Okay.
I guess this is an adult patient, you said, Dr. Pass?
Adolescent, late adolescent.
Adolescent. Oh, that's right. It says in big letters.
Yes, those big blue letters, yes.
I think I would be hesitant to put in a pacemaker because the patient has proven to us that they're asymptomatic in the 40s, but it would at least give us, to let us know if the patient meets criteria to qualify for.
Right, so you're doing a Holter because you want to see. So right now we see two electrophysiological abnormalities. We see two electrophysiological abnormalities. The first is that the patient is bradycardic and has sinus node dysfunction. And the second is that there is first-degree heart block. And we don't understand why either of those facts are in this patient. And so you would want to do a Holter because you would want to see what happens to the sinus node when a patient exercises. And Rachel Moss is asking, would be worried about this patient's ability to compensate an exercise? And would we want exercise stress test? The answer is maybe, but we could also do a poor man's stress test and just ask the patient while wearing the Holter or the Zeo patch to exercise to see what happens to conduction, and which is what we did. And so you really want to make sure that this is as bad as it gets. Now, there is no indication with first-degree heart block is not considered a class 1 or a class 1A or a class 2A indication for implantation of a pacemaker. Sinus node dysfunction in the setting of chronotropic incompetence would be an indication for a pacemaker, but this patient is completely asymptomatic. I should also mention that a Holter was done before we saw this patient, although I put my own 7-day Zeo on this patient, and it showed that she can go to 165 beats per minute, 1-to-1 with a long PR interval. So I don't actually know what this patient has. I don't understand why they're this bradycardic. This falls into the bag of idiopathic, but I think that this is certainly something we would be concerned about, and I would generally recommend monitoring somebody like this. I well recall I had a patient for many, many years who had a PR like this, did not have sinus node dysfunction, but had a long PR. And actually, when we did do a stress test on her, and she would actually shorten her PR a little bit to like 210 when she would exercise, from about 280 when she was just at rest. So I felt pretty confident that everything was okay. And then when she was about 19, she came to the emergency room following a syncopal episode, and she was in complete heart block after having been monitored by me for about 8 or 9 years in first degree block. And we put a pacemaker in her. So anyway, it's an interesting case. Thought I'd show it with you. Let me just go to the next one. This is an ECG obtained on a patient, and this was obtained the morning after an ablation. Thankfully, not my ablation, but an ablation. So I'm going to ask Dr. Babia what he would do if he, in the olden days, we would admit everybody after ablation and monitor them. Let's say this is a WPW patient, and this was seen on the 12 lead in the morning, the pre-discharge EKG. What are you seeing, and anything you need to do about it? Should we just discharge a patient?
Looking at the second lead below, I believe this is it's definitely heart block. Let me see what kind of heart block it is. So I see that the PR is lengthening, and then there's a dropped beat on the technically third P wave. The only thing is it's probably third degree block, I think, rather than a second degree.
So in third degree heart block, what happens to the RR interval usually? Is it close?
Yeah, it
Or
should
is
be
it variable?
should be the same.
All right. Is this a fixed RR interval, or is it variable?
No, it's not. It's variable.
Okay, so seems unlikely on that criterion that, now I understand in complete heart block, your RR interval will change, but it doesn't change over a 3 to 6 second period usually. So, so I would say this is not complete heart block. So then what kind of heart block it is? Now, first degree heart block, we know is every P wave is conducted, but I think we would agree that there are a handful of P waves on this tracing that are not conducted. And so this is not first degree, and it ain't third degree. So what other degree could this be?
Second.
Right. And so then the question is, are we looking at Mobitz 1 or Mobitz 2?
Yeah, well, the first part of this second lead looks like it's a first Mobitz 1, I mean. But then the second part of this lead looks like it's not.
Well, I mean, the thing is, right, this, of course, it's a hard tracing to interpret because there's no lines on the EKG, but the atrial rate in this tracing, let's say for the sake of discussion, is say 60 beats per minute, okay? This P wave is very shortly, so I think this is Mobitz 1, clearly, right? The PR interval is lengthening, and then there's a P wave that's dropped. Then this P wave comes in, and this QRS, this is almost like a junctional escape beat. So this P wave is not conducting, but it's not conducting because the QRS is too soon. This junctional beat is earlier. We don't really know if this would have conducted. This P wave you would have imagined should conduct, but it's still at a rate of about 100 or 100 and maybe 110 after the last QRS. So normally we would expect a healthy AV node should conduct this beat. So this is a little worrisome, but it's a single beat. Then this, again, we have a P wave with a junctional escape beat. So the fact that this does not conduct is not necessarily worrisome. But then this P wave here which is at a coupling interval of about 100, 120 after the last QRS, should normally conduct. So we would call this probably Mobitz 1 block with junctional acceleration, sinus bradycardia. And so your patient has had an ablation, and this is what you're seeing. So what would you do?
And this is day one, right after the surgery. So,
Post-op day one, you're in the morning. You know, in the old days, we used to admit every ablation. We'd watch them overnight on telemetry. And in the morning, we would get an EKG and an echocardiogram and discharge them. We echoed everybody. We almost virtually never found anything. In fact, I believe I'm an author on a paper by Chris Jansen in which we basically found that we found nothing. And so that stopped the process of just blindly echoing everybody who had an ablation. There are people who need them, but it's unusual. But anyways, the point is, yes, we're post-op day 0 or 1 after an ablation, and this is what you're seeing. This is clearly suboptimal finding. So anything you could do about this, or what would you do? Would you send the patient home?
would I send the patient home? I guess I would, except that I believe that we can see some degree of heart block within the first week after the ablation, meaning I would rephrase, if we see it we can't see it for 1 week and then it can go away because of the improvement of the inflammation reaction. If it stays longer than 1 week, then most likely we've done some permanent damage. We can give some steroids to treat the inflammation and maybe help to recover.
So let me interject. So yes, you can see this from inflammation, but this is absolutely not something you'd ever want to see. So yes, it's true that you could see this after an ablation, and yes, it could be from inflammation, but you would never consider this a normal or a usual finding following an ablation. This is a bad thing to see. It suggests that there has been injury to the AV node as a result of the ablation. And so, yes, we would not send someone home like this because we would be concerned that it would even progress farther. You know, we would not have left the lab. In other words, if we left the lab with sinus rhythm with a normal PR interval, and we're seeing this the next morning, it's a very worrisome finding, suggesting that there is inflammation and that there is what we sometimes refer to as lesion creep, meaning that the lesions we made, which were close to the AV node and were not causing any obvious AV nodal injury, were now causing AV nodal injury. And so, yes, we would give anti-inflammatory medication like steroids, and we would observe this patient, and we would probably move this patient to the ICU because of concerns that the heart block may progress. And so that's what we would normally do. One time, and I've had a handful of patients, maybe 3 or 4, who had some prolongation in their PR interval following ablations near their AV node that were not observed in the cath lab. But one time I had a patient who had perfectly normal conduction during a slow pathway modification, never had a block P wave, completely normal throughout the procedure, was observed overnight, had normal conduction, had a normal ECG, came back the following week and had an ECG tracing like this, a full week after ablation. And when I saw it in the cardiology clinic, I almost fainted myself. I was so agitated and upset over the finding. And I admitted the patient, put them on very high dose steroids, and amazingly and thankfully it resolved, but it was very scary. And this is not ever a normal finding following an ablation. So you should always be very concerned if you see any degree of heart block. And this is the reason why we're so aggressive, or I am so aggressive in screaming the word off when we're ablating anywhere near the AV node if we see even one non-conducted bead or a prolongation in the AH interval, because this is what we are trying to avoid. This is a very bad problem if we see this after an ablation. And with that, I think we're going to stop because it's 7:45. Thank you very much for joining, and I'll see you in a few minutes at sign out, guys. Have a great week, everybody. Take care.
Thank you.
you.
Bye-bye, guys.